Hello friends. Now I'm with my another topic and second part of normal growth. This is the second video of growth. Now discuss the topic disorders of growth. Short stature. Definition. This is most important topic. Mainly asked many of times in university exams and also in NEET PG, INICT also. And now definition. See that look at the definition. Look at the definition. Short stature is defined as the height below third centile or more than 2 standard deviation. Definition according to the standard population as is evident, height below the third percentile or more than 2 standard deviation below the median height for age and gender less than -2 SD according to the population standard. As is evident from the definition, approximately 3% of the children in any given population will be short. Children whose stature is more than 3 standard below the population mean for age and gender less than -3 SD are more likely to be suffering from pathological short stature as compared to those with a stature between -2 and -3 SD who are more likely to be affected by physiological and that is familial and constitutional short stature. Etiology. Short stature can be attributed to many causes: undernutrition, chronic or systemic illnesses, common etiological factor followed by the growth hormone deficiency, hypothyroidism. Steps in assessment: accurate height measurement, assessment of height, velocity, comparison with population norms, comparison with child's own genetic potential, assessment of body proportion, sexual maturity rating. Okay, so causes. Look at the causes, table 2.3. Causes of short stature. More important point: physiological short stature, familial constitution, pathological undernutrition, chronic short, systemic illness, cerebral palsy, congenital heart disease, cystic fibrosis, asthma, malabsorption, celiac disease, chronic liver disease, acquired immunodeficiency, its endocrine cause, growth hormone deficiency, insensitivity, hypothyroidism, Cushing syndrome, pseudohypothyroidism, precocious or delayed puberty, psychosocial dwarfism, children born small for gestational age, skeletal dysplasia, achondroplasia, rickets, genetic syndrome, Turner, Down syndrome. Okay. Steps for assessment: accurate height measurement. For children below 2 years, supine length should be measured using an infantometer with a rigid headboard on side and movable footboard on other side while holding the infant straight on the horizontal board. For older children, height should be measured with a stadiometer. Older children, height measured with a stadiometer. Children below 2 years with infantometer. Children will more than older children stadiometer as explained previous section. Okay. Height assessment of height velocity. Height velocity is the rate of increase in the height over a period of time expressed as centimeter per year. The average height velocity is 25 centimeter per year. In the first year, declines at 4 to 6 centimeter per year in prepubertal children between 4 and 9 years of age and increase during puberty, and peak height velocity of 10 to 12 centimeter per year. If height velocity is lower than expected for age, the child is likely to be suffering from pathological cause of short stature. Comparison with population norm. The height should be plotted on appropriate growth chart and expressed in centile or as a standard deviation score. Comparison with child's own genetic potential. Parents' height significantly affect the child's height. Mid-parental height gives an approximate estimate of the child's genetically determined potential. MPH for boys, mothers plus father's height upon 2, mothers plus father's height upon 2 plus 6.5 centimeter per. Okay, MPH for girls, mid-parental height for girls, mothers plus father's height upon 2 minus 6.5. MPH for boys is mothers plus father's height centimeter upon 2 plus 6.5 centimeter. MPH for girls, mothers plus father's height centimeter upon 2 minus 6.5 centimeter. This value is plotted on the growth chart at a 18 to 20 year adult equivalent of age. This gives an estimate of the target height for the child and percentile that she is likely to follow. Assessment of body proportion. Short stature can be proportionate or disproportionate. The proportionality is assessed by upper segment is to lower segment ratio. The proportionality assessed by upper segment and lower segment ratio, and comparison of arm span with height. US can be measured by taking the sitting height of the child. Upper segment can be measured by taking the sitting height of the child. Child is made to sit on a square stool placed against the vertical rod of the studiometer. The headboard is down to the vertex. Similarly, as for taking height, the height of the stool is subtracted from the reading obtained to get sitting height. Alternatively, LS can be measured by taking the length from pubis symphysis to the ground while the child is standing erect. This is for lower segment. Okay. Lower segment can be measured by the length from pubic symphysis to the ground while the child is standing erect. For measuring arm span, child is asked to stand with both arms extended outward parallel to the ground. Length between the tips of the middle finger of the outstretched hand is the arm span. Normally, US-LS ratio is at birth 1.7, at 3 year of age 1.3, 6 year 1.1, 10 year 1, in adult 0.9. Increase in US-LS ratio, it is a pathological condition seen in rickets, achondroplasia, and treated congenital hypothyroidism. Decrease in US-LS ratio seen in spondyloepiphyseal dysplasia, vertebral anomaly. Arm span is shorter than length by 2.5 centimeter. At birth, equal at 11 year, slightly less than. Thereafter, it's slightly greater than the height. Okay, arm span is shorter than length by 2.5 centimeter at birth, equal height at 11 year, and thereafter is slightly less than 1 centimeter, usually less than 1 centimeter greater than height. Sexual maturity. SMR is a stage should be assessed in older children. Height spurt is seen early puberty in girls and mid puberty in boys. Precocious puberty can lead to early height spurt followed by premature epiphyseal fusion, ultimate short stature. On the other hand, delayed puberty can also present with short stature in adolescence, as the height spurt is also delayed. Differential diagnosis. Diagnosis is based on the detailed history, examination, and laboratory evaluation. Careful history and examination can be unveiled many clues to the etiology of short stature. The investigative work up to be done is guided by clue from the history and physical examination. Bone age assessment should be done in all children with short stature. The appearance of various epiphyseal center and fusion of epiphysis with metaphysis tell about the skeletal maturity of the child. Mark the sentences that I'm marking is very important sentences. Bone age is conventionally read from the radiograph. Of the left hand and wrist using either Coolidge Pile Atlas and Tanner Whitehouse method. It gives an idea as to what proportion of the adult height has been achieved by the child and what is the remaining potential for height gain. Bone age is delayed compared to chronicle age in almost all causes of short stature. Exception to this family short stature, these are family of short stature in which bone age equal to chronicle age. In which bone exceed chronicle age. 2 points you can find exceptions. Familial short stature in which bone are age equal chronicle age, and precocious puberty in which bone age exceeds chronicle age. In case constitution delay under nutrition system illness, bone age is less than chronicle age and correspond to height age. In case growth hormone deficiency and hypothyroid, bone age may be lower than height age if the endocrine condition is undiagnosed late. In addition, all children with disproportionate short stature require skeletal survey to rule out skeletal dysplasia and rickets. Essentially, screening investigation that should be done in all children with short stature are listed in table 2.16. Okay, on another page. If these investigations are normal and bone age is delayed, level 2 investigation should be done. If these investigations are normal, then the major diagnostic possibility are growth hormone deficiency and malabsorption. Okay, if the child has borderline short stature, that is height between -2 and -3 standard deviation, then it is prudent to wait for 6 to 12 months and observe her for height velocity. On the other hand, if the child significantly short less than -3 st 3 standard deviation or has documented poor height velocity over 6 to 12 months, one should proceed to level 3 investigation. So we left these tables to finish this page completely. This clue to etiology of short stature from history: low birth weight, polyuria, chronic diarrhea, greasy stool, neonatal hypoglycemia, jaundice, micropenis, headache, vomiting, visual problem, lethargy, constipation, weight gain, inadequate dietary intake, social history, delayed puberty in parents. Okay, etiology: small for gestational age, chronic renal failure, renal tubular acidosis, malabsorption, hypothyroid, pituitary or hypothalamic space occupying lesion, example craniopharyngioma, hypothyroidism, undernutrition, psychosocial dwarfism, constitution delay of growth and puberty. Clue to etiology of short stature for examination finding etiology: examination finding disproportionation, dysmorphism, pallor, hypertension, frontal bossing, depressed nasal bridge, crowded teeth, small penis, coitus, coarse skin, central obesity, striae. Etiology: disproportion, skeletal dysplasia, rickets, hypothyroid, dysmorphism, congenital syndrome, pallor, chronic anemia, chronic renal failure, hypertension, chronic renal failure, chronic renal failure, frontal bossing, depressed nasal bridge, crowded small penis, hypopituitary, coitus, coarse skin, hypothyroidism, central obesity, striae syndrome. Okay, specific etiologies: familial short stature, constitutional growth delay, undernutrition, endocrine cause, skeletal dysplasia, genetic syndromes, psychosocial dwarfism, child born small for gestational age. All this is important, and management also. Okay. So now come to the specific etiologies. Familial short stature: the child is short as per definition, height less than 3rd percentile, but is normal according to his own genetic potential determined by parents' height. These children show sketch down growth between birth and 2 years of age, so that the height and weight come to lie on their target mid-parental centiles by the age 2 year. Subsequently, the growth velocity remains normal throughout childhood and adolescence. The body proportion is appropriate and bone age equal to the chronicle age. Puberty is achieved at appropriate age and final height is within their target range. Figure 2.20, you can see the graph growth chart of a girl with familial short stature. The child is growing below and parallel to the third centile from early childhood till adulthood. Height velocity is normal. Bone age corresponds to the chronicle age target height. Okay. So now, in previous page, it is mentioned about table 2.16. Now look at table 2.16. Stepwise investigation workup for short stature. More important, you have to mark this. Okay. Level 1 essential investigation, level 2 investigation, level 3 investigation. Level 1 investigation, complete hemogram with ESR, bone age, urine analysis including microscopy, osmolality, pH, stool examination of 4 parasites, steatorrhea, occult bloodiuria, creatinine, bicarbonate, pH, calcium, phosphate, alkaline phosphate, fasting glucose, albumin and transaminase. Level 2 investigation, serum thyroxine, thyroid stimulating hormone karyotype in girls to rule out Turner syndrome. Level 3 investigation, serology, anti-endometrial, anti-tissue transglutaminase antibodies, provocative growth hormone testing, serum insulin-like growth factor and insulin-like growth factor, binding protein 3 level, MRI brain for those with low peak growth hormone level. Constitutional delay, growth delay. These children are born with normal length and weight, grow normally for first 6 to 12 months of life. Their growth then show a deceleration so that the height and weight falls below the third centile by 3 years of age. Normal height velocity is resumed and they continue to grow just below and parallel to the third centile with a normal height velocity. The onset of puberty and adolescent growth spurt is also delayed in these children, but final height is within normal limit. Bone age is lower than chronicle age and corresponds to the height age. History of delayed puberty and child and delayed height spurt is usually between one or both parents. Table 2.17, you can see distinction between constitutional delayed growth and family short stature. More important feature, constitutional growth, one is given constitutional growth. Put this, make the table by your hand. It help in what? Sometimes we have to waste time to get more output. This is the table. Feature, constitutional growth delay, family short stature, height, short, velocity, family history, height, velocity, normal, family history, delayed puberty, short stature, bone age less than chronicle age, puberty, delayed, normal, bone age, puberty. Remember these. Final height normal, low but normal for target height. Okay. Undernutrition. Stunted growth caused by chronic undernutrition is one of the commonest causes for short stature. Our country, India. Detailed dietary history and presence of other features of malnutrition such as low mid-upper arm circumference and low weight for height suggest the diagnosis. For diagnosis, we have to take upper arm circumference, low mid-upper arm circumference, and low weight for height. Okay, endocrine causes. These are discussed in detail in chapter 17. Okay, endocrine causes. Skeletal dysplasia, inborn error in the formation of cartilage and bone cause chondrodysplasia or skeletal dysplasia, inherited or sporadic conditions that are usually associated with abnormal skeletal proportion and severe short stature. A careful elicitation of family history, measurement of body proportion, examination of the limb and skull and skeletal survey are required for diagnosis. Genetic syndrome, Turner syndrome, with an incidence of 1:12,000 live births, is a common cause of short stature. Number 10 point. Also asked in exams, competitive exams, in girls and should be ruled out even in if the typical phenotypic feature are absent. Other syndrome associated with short stature are Down Prader-Willi, Russell Silver, and Shackle syndrome. Psychosocial dwarfism. This condition, also known as emotional deprivation dwarfism, maternal deprivation dwarfism, or hyperphagic short stature, is seen in children in unhappy homes where the emotional needs of the child are totally neglected. It is characterized by functional hypopituitarism indicated by low IGF level and one inadequate response of GH2 stimulation therapy. With GH is, however, not beneficial. Good catch-up growth is usually seen when the child is placed in a less stressful environment and nurtured with love and affection. Children born small for gestation age, birth weight below the 10th centile or for gestational age can be caused by maternal, paternal, fetal factor. Most of these infants show catch-up growth by 2 years of age. However, an estimated 20 to 30% of babies born SGA fail to show catch-up growth and maintain short stature. Subtle defects in the growth hormone and insulin like growth factor axis are considered responsible for short stature management. The general principle for management for any child who's present with short stature include counseling of the parents and dietary advice. General principle include counseling of the parents and dietary advice. Parents should be counseled to highlight the positive aspect of the child personality and not put undue emphasis on stature. Intake of a balanced diet containing the recommended amount of macro and micronutrients should also be recommended. The specific management will depend on the underlying cause. For physiological cause, reassurance and annual monitoring of height and weight is sufficient. Dietary rehabilitation for undernutrition and treatment of underlying conditions such as renal tubular acidosis, celiac disease are generally associated with good catch-up growth. With any form of therapy, monitoring with regular and accurate recording of the height is mandatory for satisfactory outcome. For skeletal dysplasia, limb lengthening procedures are offered at few orthopedic centers. For hypothyroidism, levothyroxine replacement is advised. For growth hormone deficiency treatment, daily subcutaneous injection of GH is recommended. GH therapy is also approved for several other conditions, though the dose required are generally higher and improvement in final height is smaller and more variable as compared to the GH deficiency. Some of these conditions are Turner syndrome, SGA with inadequate catch-up growth, and chronic renal failure prior to transplant. failure to thrive. This topic also important. Definition and epidemiology. FTT is a descriptive term rather than a diagnosis and is used for infant and children up to 5 years. Use up to 5 years of age whose physical growth is significantly less than their peer of same age and sex. FTT usually refer to weight below 3rd and 5th centile, failure to gain weight over a period of time, or change in rate of a growth that has crossed two major centiles 75 and 50th over a period of time. The prevalence of FTT vary according to the population sampled. Etiology. Traditionally, FTT is classified as organic, where the child has some known underlying medical condition, and organic or psychosocial, where poor growth is a result of inadequate caloric provision or emotional deprivation. Organic, non-organic etiological factor may coexist. Example, in children with cerebral palsy or multiple congenital anomalies, FTT is non-organic in up to 80% of cases. The common etiological factors are listed in table 2.18. Causes. More important topic. Organic cause, non-organic cause. Organic cause: gastrointestinal, neurological, cardiopulmonary condition, endocrine, infection, genetic, miscellaneous. Okay, non-organic cause: poverty, misperception or lack of knowledge, the top feeding, lack of breastfeeding, feeding, dilute formula, dysfunctional parent-child relationship. Dysfunctional parent-child relationship mainly in broken families. What is broken families? Broken families, those couples who are separated or divorced. Okay. Clinical feature: these children present with poor growth, often associated with poor development and cognitive functioning. This degree of FTT is usually measured by calculating weight, height, and weight for age as percentage of median value for age based on appropriate growth chart. Diagnosis history: physical examination and observation of the parent-child interaction are important. Detailed laboratory investigation are needed only if the history of physical examination suggested that an organic cause is responsible for FTT and localize the system involved. For initial evaluation of the following investigation are to be complete: blood count with ESR, urine, stool microscopy culture, renal and liver function test, and serum electrolyte. Weight gain in response to adequate calorie feeding establish the diagnosis of psychosocial FTT. Management: the goal of management are nutritional rehabilitation, treatment of organic cause if present, and remedial measure for psychosocial factor. Important indication for hospitalization include severe malnutrition. Diagnostic and laboratory evaluation needed for organic cause: lack of catch-up growth during outpatient treatment, suspected child abuse or neglect. The management of these patients depend on underlying cause. National rehabilitation is necessary. If managed early and adequately, the prognosis for physical growth recovery is good. However, the outlook for cognitive, emotional, and behavioral development is variable and less certain. The growth and development of these children should be monitored regularly. Abnormality of the head size and shape. Head growth may be affected by abnormal growth of the skull bone or alteration in brain parenchyma, cerebral spinal fluid, or bone. Macrocephaly. Macrocephaly is defined as an occipitofrontal circumference greater than 2 standard deviation above the mean for age. Macrocephaly is also an important topic. Definition. This is the definition. Occipitofrontal circumference greater than 2 standard deviation above the mean for age and sex. Table 2.20. Cause of macrocephaly: megaloencephaly, increased cerebrospinal fluid, enlarged vascular compartment, increase in bony compartment, miscellaneous cause. These are the causes of macrocephaly. And Megalencephaly and enlargement of the brain parenchyma may be familiar or associated with inherited syndrome or neurometabolic disease. Infant with benign familial megalencephaly have increased head size at birth that persists throughout infancy along the upper growth curve percentile and is associated with normal body size, neurological examination and development. Children with metabolic cause have a normal head circumference at birth. Microcephaly is noted as the child gets older. Diagnosis is suggested by accompanying feature biochemical abnormality. Hydrocephalus is characterized by an excessive amount of CSF may be caused by increased production, decreased absorption, or obstruction to CSF flow. Most of patients show postnatal rapid. Mark this sentence. Characterization. Okay, most of the patients show postnatal rapid increase in head size and are symptomatic due to underlying disease and raised intracranial pressure, nausea, vomiting, irritability. Pain and enlargement of the subarachnoid space is relatively common and is characterized by the height growth velocity that slow to normal by 6 months of age. Development assessment and neurological examination are normal. Evaluation for microcephaly is indicated if the head circumference above. Indication for evaluation is if head circumference above 3 standard deviation mean for age sex or when serial measurement reveal progressive enlargement as suggested by increase by 2 cm during first 6 months of life. The crossing one or more major percentile lines between routine visit measurement of the head size in parent is useful in diagnosing familial cases. Majority of patients require cranial imaging, ultrasonography, USG, and computed tomography CT scan. Child with asymptomatic familial megalencephaly or benign enlargement of the subarachnoid space do not require treatment. Infant with hydrocephalus may require neurological intervention, placement of the ventriculoperitoneal shunt. Microcephaly means an occipitofrontal circumference more than 3 standard deviation below the mean for age and gestation. Defining microcephaly as more than 3 standard deviation below the mean for is likely to be associated with genetic and non-genetic disorder. Associated with genetic non-genetic affecting the brain if defined more than 2 st below the mean is. Since the latter way include intellectually normal healthy children with head circumference at the lower end of the population distribution, the term primary microcephaly is used to describe condition associated with the reduced generation of neuron during neural development and migration. Secondary microencephaly follows injury or insult to a previously normal brain, causing reduction in the number of dendritic process and synaptic connections. Microencephaly is the term used for an abnormally small brain based on finding on neurological imaging or neuropathology. Since head growth is driven by brain growth, microencephaly usually implies microcephaly usually implies microencephaly, except in craniocytosis, in which skull growth is restricted. Important causes of microcephaly are listed in table 2.21. Hey, I have one mnemonic for you for the causes of microcephaly. Write down. M I M E. For the causes of microcephaly. Okay. megalencephaly, increased cerebrospinal fluid, miscellaneous causes, enlarged vascular compartment, increase in bony compartment. I denotes increase in cerebrospinal fluid, increased bony compartment. Now causes of microencephaly. Microcephaly. Isolated microcephaly, autosomal recessive, autosomal dominant or X-linked, syndromic, trisomy, monosomy syndrome, structural disease, neurotubal defect, lissencephaly, cystencephaly, polymicrogyria, pachygyria, metabolic disorder, infections, teratogens, perinatal insult, endocrine. I have one mnemonic for microcephaly causes. Write down P I E T I S M S. These mnemonics will be helpful for you. Patisms. Okay. This is the mnemonic for causes of microcephaly. What are the causes? P for perinatal insult, I for isolated microcephaly, E for endocrine causes, T for teratogens, then I for infections, S for syndromic, M for metabolic disorders, and then for S for structural diseases, neurotubal defect, lesionencephalo, cystencephalo, polymicrogyria, pachygyria. Okay. Now come to the paragraph. Now come to paragraph. Isolated inherited microencephaly most commonly as an autosomal recessive phenotype. Is associated with reduced OFC since birth, normal cerebral autonomy, and absence of neurological sign with or without learning difficulty. Other associations include structural pain, malformation, inherited syndrome, congenital or acquired infection, hypoxic ischemic insult, and rarely metabolic disorders. Evaluation for microcephaly should be initiated if a single head circumference measurement is more than 2 to 3 SD below the mean, or when serial measurements reveal progressive decrease in head size. Careful history and physical examination are necessary, including development assessment and measurement of the head size of parent. Need for neuroimaging is determined by the age of onset, severity of microcephaly, head circumference in parents' history of antenatal insult, and associated clinical feature. And abnormal head shape and ridges along the suture line are suggestive of craniosynostosis. The prognosis depends upon the underlying cause and worse for secondary than primary microcephaly. The child should be managed in consultation with genetic and pediatric neurology service. Okay. Head of normal unit. This is one for normal one. And B so trigocephaly, and C brachycephaly, D left anterior plagiocephaly, E scaphalocephaly, F right posterior plagiocephaly, and position is coming without. Okay. Craniosynostosis. Maybe asking one question, one mark MCQ or short answer type question for 1 mark or 2 mark. Craniosynostosis is the premature fusion of one or more cranial suture. This Image 4 craniosynostosis. Either major or minor. Cranial suture normally fused during early childhood, starting with the metopic suture, beginning at 2 months, following the sagittal coronal lumbar suture, such that the frontonasal and frontozygomatic suture close at 68 to 72 months. Premature fusion restricts the growth of the skull perpendicular to the affected suture. Compensatory skull growth occurs parallel to the affected suture in order to accommodate the growing brain. The resulting skull deformity is termed scaphaloencephaly, plagiocephaly, and trigonocephaly. Based on the suture involved, cloverleaf skull deformity is caused by fusion of multiple sutures and associated with the hydrocephalus. Important sentence. Patients with tower skull and acrocephaly have combined sagittal coronal and lumboidal synostosis, often as a part of upper and crucian syndrome. Oxycephaly and touriscephaly refer to tall cranium resulting from delayed repair of brachycephaly and is often syndromic. Upper syndrome is an autosomal dominant sporadic disorder caused by defect in fibroblast growth factor gene, characterized by coronal synostosis and maxillary hypoplasia associated with the recessed forehead, flat midface, protruding eyes, hypertelorism, anti-mongol slant of eyes, low set ear. Most patients have high syndactyly. Other findings are strabismus, conducting hearing loss, airway compromise, and severe acne. Crucian syndrome is an autosomal dominant disorder caused by mutation in FGFR2 and FGFR3, characterized by tall, flattened forehead, proptosis, peak nose, and mid-face hypoplasia. Many patients have cervical spine abnormality. The degree of facial deformity is milder than in Apert syndrome, and patients do not show cleft palate, syndactyly, mental retardation, and other conditions associated with cranial synostosis or Carpenter syndrome or Pfeffer syndrome. So now we finish the one chapter of Pediatrics edition Ghai, edition 8th edition of Ghai.